Welcome to Season 2 of Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets dermis comedy. I'm Matt Zires, and each week I'm joined by my residency buddies, Dr. Laura Ferris from the University of North Carolina and Dr. Tim Patton from the University of Pittsburgh, where we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll actually have some fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and other major podcast platforms. And to remind everybody, there is a video component which has some of the key figures and tables from the articles that we talk about. So this week, we've got another one of our patented six-pack episodes where we are going to go over what is the coolest, most interesting new stuff in the literature from our perspective. Dr. Ferris, why don't you start us off?
All right, Matt, I'm going to start with Merkel cell carcinoma.
Ooh,
everybody's
Merkel.
favorite neuroendocrine skin tumor, I know. So this was
Wait,
actually...
I got a question for you two, first of all. If
Yeah.
you had to ballpark it, how many Merkels have you actually seen in your real life in your clinic? Pat, and you first.
One.
Ferris?
I have diagnosed 2 and probably followed about 5 or 6 patients.
All right. So
I follow a couple Merkels, but
okay. So
coming into
I
the
had
office,
one
doing the
at
biopsy.
the University of North Carolina in my first 6 months here.
Okay.
And
so
it was on my differential, so it made me look like I knew what I was doing.
Okay, nice.
I always put it on my differential.
Yeah, I've never diagnosed one.
Eczema.
So.
Yeah.
Eczema versus Merkel.
I feel like
eczema versus Merkel. You never know.
Talked about a ton, but they're just pretty darn rare whenever you really look at it. But all right, Ferris, go ahead.
Yeah.
Okay, so this is Gunnell et al. This was in JAMA Dermatology, and this is polyomavirus antibodies for Merkel cell carcinoma recurrence detection. So this is Paul Neam's group in Seattle. They are sort of like the gurus of Merkel cell carcinoma. And so they have really specialty Merkel cell. That's all I think that Paul does as far as I know. And they really have the largest patient population. So they are kind of like my go-to experts for Merkel cell carcinoma.
Okay. All right. Okay. Some credibility.
Yep, credibility. So they ran what I think is probably the most, comprehensive study on Merkel cell polyomavirus oncoprotein antibody titers for Merkel cell carcinoma surveillance. So do you know what those are, Matt?
I mean, I do now, but I didn't 4 days ago.
Yesterday? Yeah. Okay, so basically, we know that, interestingly, overall from the study, about 80% of patients with Merkel cell carcinoma harbor Merkel cell polyomavirus.
Wait, how many? 80% you said?
About 80%
okay.
of patients actually do. Now, in this paper, 50% of patients had the antibody, but when they went back and looked at all of them, there was sort of this 30% group that was antibody negative, but when they, looked at their tumor, they could actually identify virus in there. So that's where I'm giving you that 80% number. Okay, so Merkel cell polyomavirus, basically, we all have MCV, most of us, that we bet that's it's around. It's just, it only kind of integrates in and causes Merkel cell carcinoma in a subset of patients. It turns out that
wait. You said we all have MCV?
Merkel cell polyomavirus, yeah.
Okay. Sorry. Yeah. Got it. Merkel cell virus. Okay. I was like, we all have a mean corpuscular volume.
We also have that, but that's
what
that too. With us. Yeah.
Okay. All right. Go ahead. So
Yeah.
we've all got the virus, but most of us don't.
So most of us have been exposed to the virus, but it doesn't, we don't have Merkel cell
Okay.
carcinoma. Okay. So anyway, what happens is that when you have the virus that integrates and causes the cancer, it exposes this neoepitope and you make an antibody to that. So that antibody is a marker that says, yes, you have Merkel cell carcinoma that is virally driven. So this can be useful in following patients. So they had 500.
So you don't. So even though most of us have the virus, we don't
have that antibody.
Okay. All right. Go ahead.
Okay. So 503 patients with stage 1 to 3 Merkel cell carcinoma were followed for a median of a little over 4 years. They had blood tests every 3 to 6 months measuring titers of this antibody. This antibody is called AMERC. It is a test. By the way, you can order it if you search AMERC. You can order it at the University of Washington. So you can, order the test. Your patient can get it drawn and they can send it off. So anyway, what they found in the study, so, they followed patients from diagnosis and then every 3 to 6 months. And so what they found was, one, the higher your baseline AMERC titers, the higher your chance of recurrence. They also just sort of, they also found that if you are a
Wait. That was not what I took from that graph. So
that was baseline.
Yeah. So probability of recurrence-free survival, if you were seropositive, you had a higher probability of recurrence-free survival. And if you were seronegative, you had a lower probability. Yes. So it was good to have the antibody.
It's good to have the antibodies, but now we're talking for the people who are positive. What is your titer of antibodies?
Oh, so the higher your titer, so you want to be positive and low titer. Right. That would be the ideal.
Yes.
Okay.
So in seropositive patients, so the people who have the antibody, having a falling or negative, so having falling titer, so either a negative titer, so we're talking now when we are doing surveillance throughout your course, having a falling titer or going to a negative titer predicts like over a 99% chance of being recurrence-free for 3 months and like a 98.8% chance of being recurrence-free at 6 months. So low titer is good. And then on the flip side, if you have a single rising titer, your risk of recurrence goes up to like 36% in 3 months or up to like 68% in 2 years. So, basically you following these titers, it can be really helpful. Because it lets you know, like, who do I need to worry about and who do I not need to worry about? And I think sort of the end game of this is if your titer is falling and particularly if you go to a negative titer, you could potentially avoid getting, CT scans or PET CT scans in that situation. The titer the rising titer also was helpful because it flagged recurrence before clinical or like image-based detection in over half the cases with a median lead time of about 4 months. So rising titers were not always like immediate imminent recurrence, but they did suggest that you were at risk of recurrence. And then they looked at it sort of like on a per test basis and also on a per patient basis. So, patients who had substantially higher risk of recurrence, so they had a substantially higher risk of recurrence after a rising titer versus with a falling titer with it like a hazard ratio of like 51.
Wow.
Okay. So yeah. So then the other thing that was kind of interesting is that the same group recently had an ASCO abstract where they also looked at circulating tumor DNA and AMERC in the same patient. So 2 different biomarkers. ctDNA is circulating tumor DNA. Now that's going to be, that's not virally dependent. So Merkel cell carcinoma that is virus negative can also have, will also shed tumor DNA, but what they wanted to do was look in the patients where they could follow both. And so they had 171 patients, over 700 paired samples. In that group, they had 38 recurrences. So what they found was actually that a positive ctDNA was actually sort of a more ominous or worse prognostic factor than a positive AMERC test. So the hazard ratio for recurrence was over 27 with ctDNA versus 5.8 with, rising AMERC. So ctDNA positivity was more strongly associated with recurrence. This is an abstract, so if you're going to ask me like every last graph, I can't tell you. All right.
You've already told me more than I wanted to know.
Okay. 1 year positive predictive value, 73% for ctDNA versus in that series, 51% for AMERC. So putting that all together, it is, if your patient has a falling or negative AMERC titer, very reassuring. You could probably, you could probably space out their surveillance. Are we going to be the one necessarily doing this? Probably for the average derm, no. But I think it's nice to know. And I also think it's helpful. Why do I think that this is helpful? This is a test that we can order. And, particularly if your oncologist wants to use this, which many of them probably do, you can at least send out, order the AMERC test, send the patient. So when they go to see oncology, they have a baseline. And I think that, time is kind of the essence when we have these tumors. So, I thought that was sort of helpful. What kind of imaging? The authors said that they generally do PET CT because it's more sensitive, and that is their preferred imaging if it's available. CT scan if you can't get, PET CT. So it's kind of the liquid surveillance era. I thought it was cool.
All right. So the quick summary: when you're diagnosed with the Merkel cell, it's good if you've got the antibodies because you got a higher overall survival there right at the beginning. But then once you've got the Merkel cell, you want your titers to be stable or falling. If your titers are rising, that's bad. And if you've got tumor DNA in your blood, that's bad.
You got it.
All right. Patton, you got anything you want to add?
No, but right. I mean, I think for us, we have a Merkel, refer to hem-onc, maybe think about checking that AMERC. Although last patient we had with this, we couldn't do that. Like our send out lab was like, what are you talking about? And so it was 6 months before we figured out how to do it. And they do recommend that AMERC initial test be done within 3 months of the initial diagnosis. Because if you cut out Merkel, if you're the one excising it, titers drop pretty quickly from what I understand.
Yeah, so I think I think they said about within a month of starting therapy.
Do they get Mohs or do they get wide local excision with a sentinel lymph node biopsy?
The latter.
Okay.
Everybody gets NCCN guidelines. Everyone gets sentinel node.
Yeah,
there are Mohs people that take out Merkel.
Okay.
Yes, the guidelines would say so. I think that's actually a good take-home point for the derm not practicing in a big multi-center oncology or big oncology center. You don't just send these patients to Mohs. They really need to go to surgical oncology. Everybody should get a sentinel node biopsy. If you remember nothing else, remember that.
All right.
I think they could go see Mohs, but I think as part of a multidisciplinary decision.
Yes, I'm not saying Mohs cannot be the removal, but you don't want to just say Mohs.
Yes.
You don't need to sort of enter the surgical oncology pathway.
Agree. Yeah.
Okay, let's move on, Pat. I can't wait for you to talk about this one when you put it in the thing, and I was like, oh, but I know a study that shows that collagen does. And then I was like, son of a.
Yeah, well. So that's the problem. Not that I have a huge interest in collagen supplementation, but this is the stuff. This is like the walking out the door questions where patients are like, what's your favorite sunscreen? Or what do you recommend for this? What do you recommend for that? And hey, what do you think about collagen supplements? So I was reading in the Wall Street Journal a few weeks ago, because you guys know I am sophisticated, and I saw the headline, Wonder Pills Are Waste of Money, the new supplements promising youth and beauty. And of course, my first thought was it's a huge waste of money, of course, but none of the healthcare providers interviewed said it's a huge waste of money. For some reason, they interviewed two people who are co-founders of the companies that make the supplements. Why would you do that?
Yeah.
There was one dermatologist at the end of the article who said, if you only take the supplements for a short period of time, it is going to be a waste of money. So Derms on Drugs, shout out to Dr. Hallie McDonald. I think she practices in Austin. Wall Street Journal, that was not my six-pack, but it was just a little clever lead-in to introduce my first six-pack, which is titled Effects of Collagen Supplementation on Skin Aging, a Systematic Review and Meta-Analysis of Randomized Controlled Trials by Myung and Park, and it was in the American Journal of Medicine, September 2025. I just read the Wall Street Journal article when I came across my six-pack article, so could not have come at a more timely time. Why even do this study? There were already two meta-analysis of randomized controlled trials that showed collagen supplements improve skin hydration and elasticity. We don't need to do any more. We've proven it. It works. This particular meta-analysis sought to perform the meta-analysis focusing in on study quality as well as funding sources for the individual trials. 893 records, they got down to 23, included over 1,000 patients. Conclusions, collagen supplements work, people. They actually work. They significantly improve skin hydration, elasticity, and wrinkles. I think I'll introduce one of my own and retire a gazillionaire. Except I'm neither clever or hardworking enough to found a company, so that's not going to happen. So now we can comfortably tell our patients to start taking collagen supplements, right?
No, because that study showed that it was only in the industry-sponsored studies.
Exactly. So the authors went through and did some subgroup analyses. Couple of interesting subgroup findings. Okay, so one subgroup, they looked at the source of the collagen. Fish collagen worked. Cattle or chicken collagen didn't. Pills and powders, not effective. No, you need to take collagen drinks. So like fish collagen soda, like, yeah, Mountain Dew.
Disgusting.
Come on.
Yeah. That sounds like, what is the worst beverage you could ever have?
Fish you vomit a lot, which helps with weight loss too. So, but the most interesting subgroup analysis looked at funding source and study quality. If the study was not funded by a pharmaceutical company, it didn't demonstrate any benefits. If the study was a high quality study, it did not show any benefits. And they had these quality metrics that have been, accepted as established measures of quality. So I am telling my patients that collagen supplements are very likely a waste of money. And with everyone on TikTok saying how much better their skin looks because of collagen supplements, I know my advice will have no effect whatsoever. What do you guys think?
I'm still going to be telling people to take the one that I like is called Verisol, Verisol. It's not a brand. It's a like that's an ingredient, mainly because it is extremely cheap. So it's like $6 a month. You get like a jar of the powder, and it's like 3 months worth for like $30 or something. It's like $10 a month, and they have a in themselves funded trial that is randomized, double-blind, placebo-controlled, but it was funded by them. So now
I have a couple of observations, concerns. Number one, if an industry does the study, and like, I don't think they're making shit up. Like, I think they're doing a randomized, double-blind, placebo-controlled study. Why is it that their studies work? And if somebody just goes in and says, I'm gonna look at this study, I'm gonna look at this supplement on my own, and it wouldn't work. How are they doing this? Like, consistently from this paper, how are they able to show that their stuff works?
No idea.
I mean, it could be sample size, right? You can afford to do a bigger study. You can also afford to pick multiple different endpoints if you're an industry study. It takes money to do these things.
So a few episodes ago with Dr. Tarbox, we talked about the hair supplements, and I went back to those studies. Every single one is industry funded. So whatever the supplement was, if you looked at who funded the study, Viviscal, Nutrafol, even the pumpkin seed extract, like, they're all industry. So is this probably true across all supplements that are not like drugs and don't have to go through the rigorous FDA sort of process? My sense is, yeah, probably. What do you think?
I don't know. I still like my creatine. I think it works.
Creatine is different. So creatine actually has a fair number of independent evidence. I did look at that because I'm a creatine person too. I started doing that.
What's it do for you?
Muscle.
Build muscle, decrease fat weight, increase muscle weight, blah blah blah.
Okay. Okay. Well, I'm still going to be believing industry sponsored trials for supplements. I'm still. I'm
only recommending things that have a marketer behind them because they're the only ones that work.
No, I'm going to recommend it by price. That is absolutely my defining factor. Is if it's pretty
right, because maybe this helps. Very little downsides to taking a collagen supplement. I mean, they have the radio tracer rat studies. I mean, ingested collagen does make it into tissue. You know what I mean?
Yep.
But does it actually show any clinical benefit? We don't know. So if you're going to spend money, go with the cheapest.
Okay. All right, I'm going to move on to my part of the first part of the six pack.
Your own personal six pack. Go ahead.
That's right. I get 3. Wait, are you talking about my core again? Thanks, Ferris.
We're always talking about your six pack.
It's hard not to.
So I've got some topicals here. So first, 2 that I don't really want to talk about, but just put out there. Granulomannulare, topical roflumilast worked. My main thing there would be, and that was a case report. I think oral roflumilast should be first-line treatment for GA in general. But if you could get topical covered, which you won't be able to, it worked. And then granulomatous rosacea, case report of that responding to tapinarof. So, for both aryl hydrocarbon receptor Vitama and PDE4 receptor Zoryve, great, some kind of pain in the butt things that they worked for, but doesn't really matter. You're not going to be able to get them covered. Now, let's get on to what's actually interesting here. So ruxolitinib, and believe it or not, I was first author on this article. So
self-promoting on the podcast.
Right. It's a part of Doc's Dermatology, DOCS Dermatology.
How much of the article did you actually physically write?
None, but I put together an outline. So we had a phone call, and we did a detailed outline that was kind of the draft. And then when they, then they put it together, and then I like very carefully read it, made tons of changes and recommendations and the whatever. So I did a lot.
All right.
It wasn't.
I believe it.
Yeah, it wasn't like they wrote it and I signed off on it. Like, it was a lot of work.
Okay.
So the main takeaway here. So this was efficacy and safety of ruxolitinib cream for the treatment of moderate to severe chronic hand eczema, results from a 16-week multi-center randomized double-blind study. So this was ruxolitinib versus placebo, good old Opzelura, and their IGA success rate was 53%. So we can say most people. So the big thing about this study, though, they excluded anybody with atopic derm. So it was supposed to be primarily, hand eczema of unknown etiology. So probably a mix of of allergic contact, irritant contact, and endogenous. But if you had atopic derm, it was a pre-existing diagnosis, you couldn't be in the study. So right now.
My big thing is chronic hand eczema is atopic derm, like it always has been.
So
like that,
I would argue that chronic hand eczema is always irritant contact dermatitis with either superimposed it's either ICD plus AD or ICD plus ACD or all 3. But if somebody came in and said with AD and you said, tell me about your bathing, and they said I get 6 showers a day, you would say, well, you've got some irritant dermatitis. Let's see if, maybe that's what's going on here. And since we wash our hands 6 times a day, I think they all have some irritant derm. So, and this you're getting into the problem with hand eczema. It's like, if it's not ICD or ACD, should we just call it AD? And I kind of agree that's a yes. But in a lot of the pharma stuff they talk about it, they're only going to call it AD if they have AD affecting other areas. All right. So,
and I think AD is not all one disease, by the way. The young people who get it and they've got asthma, it's a different group than the old itchy people.
Yep,
but
I agree.
They're all AD, but different flavors of it.
Yeah,
so.
I guess if somebody came in with chronic hand eczema and they never had atopic derm anywhere else, it's like, all right, you're washing. You had to say they're a cook, right?
Yeah.
That's where you can see chronic hand eczema.
Yes.
You're working with food, you're washing your hands. I know none of the other cooks have chronic hand eczema, so why do you have it? Because you probably epigenetic change, and like, to keep it simple, like an epigenetic change in filaggrin in their hand. Like, so etiologically, it's atopic derm. It happens to be localized to your hands.
Yeah.
I'm so baffled by this chronic hand eczema when they're like the first and only treat. Like, I have a lot of things that I can use to treat chronic hand eczema that are FDA approved to treat chronic hand eczema because it's atopic derm.
I would argue that it is always it's always an overlap of multiple types of dermatitis. It's either pure ICD or it's AD plus ICD or ICD plus ACD.
ACD.
So
Okay.
we're talking irritant contact dermatitis, allergic contact dermatitis.
Yes. And the reason that matters,
alphabet soup here,
and the reason that matters so much is
matters
that
more to you than anybody else out listening.
it's very clinically relevant. So topical steroids make irritant contact derm worse. So they relieve the symptoms, but they make your barrier function worse. So you stop making lamellar bodies and you stop making intercellular lipids. So whilst clobetasol will make irritant contact derm feel better, it makes underlying disease worse. And the key thing with Opzelura and Zupgo, the new delgocitinib that's specifically approved for chronic hand eczema, is that they don't have that adverse effect on the barrier. So you're much more likely to actually get people better with these than with clobetasol. Now, we don't have head-to-heads to prove that, but if clobetasol worked great for hand eczema, they wouldn't have been so excited to try and be pursuing this. But let's back to the study here. So Rux, IGA success rate of 53% versus 11% for placebo. So most people got to clear or almost clear. Now, the big question, right? And so Rux, Hexi 75 hand eczema severity index, 80% of people got 75% better versus 27% with placebo. How does that compare to Anzupgo? Anzupgo had an IGA success rate of only 25%, but there's a very good reason for all of this that I'm going to get to. So, right, it only had a Hexi 75 rate of 50%. So by sheer numbers, just looks like it's not as good as Opzelura. But number one, the two trials use different IGA scales. So clear or almost clear for the Opzelura trial could have redness and or scaling. So very minimal, barely visible scaling. For the Anzupgo trial, you could only have barely perceptible erythema. If there was one flake, you were mild. So that is a big difference. Number two, the Delgo trial was done only in Europe. The Opzelura trial was done in Europe and the US. And this was one of the first hand eczema trials in the US, so none of us knew how to do the Hexi scores very well. And then finally, the Rux trial excluded people with pre-existing known atopic derm, and Delgo didn't. And the people with known atopic derm were some of the worst responders to the Delgo, to the Anzupgo. So to some extent, in the Rux trial, they almost weeded out some of the hardest patients. So these is really a case where although by sheer numbers, I would say, well, it just looks like Opzelura was better. You truly cannot. This is a situation where we're looking at different diseases, different endpoints, very different trial populations and investigators. You really can't look at this and say that Opzelura is better than Anzupgo. You can just say both. You can say both work for hand eczema. It probably ought to be like which one is easier to get. Is probably what should be driving which one we prescribe.
Does the patient have atopic dermatitis too? If they have atopic dermatitis too, you should use Opzelura. Would you say that?
I would say that I think that whether they have if they have atopic dermatitis as well, I guess you give them Opzelura, and then. But in like a practical sense, I think they're pretty much identical drugs, with the exception that the Anzupgo doesn't have any propylene glycol in its vehicle. So that, yeah.
Do you anticipate ruxolitinib pursuing a CHE indication?
I don't think so.
It wouldn't make any sense.
Yeah, I don't. It'd be like I've always told that company, like if I'm comfortable saying that if you got hand eczema, there's a component of AD to it, unless it's pure allergic contact derm. Where try changing to a fragrance, try using only CeraVe hydrating cleanser, and if your hands get better, then fine, or change your gloves. But if treating it as allergic contact derm doesn't get them better, then I'm comfortable calling it AD already. So why spend hundreds of millions to get another indication?
It's kind of going to pose a weird situation, which I don't anticipate will actually be this clinically difficult. But say you really want Anzupgo, you've seen the data, you're like, yes, this is perfect chronic hand eczema. There's this FDA approved drug. You have chronic hand eczema, and the Delgo, it doesn't get them any better. And then you're like, I want to actually give you systemic medication. Your hand eczema is so horrible. I think Dupey's really, really going to work well. We're just going to have to change your diagnosis to atopic derm. Whereas from the get-go, it would be just like, this is atopic derm. There's a hand eczema predominant or maybe exclusive component to it. It's just weird.
I think what's going to happen is that initial diagnosis, you would call it dermatitis unspecified, treat them with Anzupgo, and then when they didn't get better, you would say, okay, it's not unspecified anymore. Now I think it's atopic.
But you don't get these letters like, there is no diagnosis of chronic hand eczema in the chart. Like I get those. I mean, not specifically CHE, but intrinsic atopic dermatitis. You just called it atopic dermatitis, or so maybe it's just the insurance environment in Western Pennsylvania.
If you're going for an AD drug, you got to say it's AD of the hands, which I think is true in most cases, like generally true. There's no way to prove it's not. And if you're going for CHE, I think you call it dermatitis unspecified of the hands.
But probably both like really good drugs, right?
Yes. I don't, we'll never have a head-to-head, but my guess would be that they're going to work the same.
Okay.
In theory, it is important that it looks now like they both seem to touch TIC2, because TIC2 seems to be more important for irritant hand dermatitis than does JAK1 and JAK2. So just interesting thing. All right, let's move on to our next article here. Dr. Ferris, what do you got next?
So I went from the most serious to the least serious. So I have efficacy, safety, and recurrence in seborrheic dermatitis, a dose-dependent analysis of oral isotretinoin, 10 milligrams versus 20 milligrams. This paper was in, I didn't write it down. Was this in JAD?
It's JAD.
It's in JAD. So I picked it because it was like an investigator-initiated study, a drug that we use a lot of, something we all see every day, and because it was done in Turkey. And because the first author and the last author have the same last name, Demirbas. Okay.
That's a good derm name.
It is like the boss of derm. All right. So what they did was, this was a retrospective study of 234 patients who were treated with oral isotretinoin 10 milligrams a day versus 20 milligrams a day. So kind of half and half, 100, a little more with the 10 milligrams a day for a minimum of 3 months, but an average of 4.2 months in the 20 milligram and 4.5 in the 10. Women, interestingly, were more likely to be on the high dose, and patients who'd had sebderm longer were more likely to get 20 milligrams. Why did they pick to treat sebderm with isotretinoin? The oil thing would make sense. Why 10 or 20 milligrams? I have no idea, but they did. So what did they find? What do you think works better? Higher dose, 20 milligrams. Better disease control, DLQI, patient satisfaction, all better with 20 milligrams. The probability of being recurrence-free. So we get to talk about recurrence-free survival across both of my papers, but in very different contexts. At 1 month was 83% on 20 and 42% on 10. And at a year, it was 36% from the 20 group and 14% in the 10 milligram group. So, adverse events, amazingly, they said there was actually more like myalgias and epistaxis in the 20 milligram group. I feel like that's, but interestingly, the 10 milligram group had more dry lips and skin. I feel like that's all kind of, I don't know.
It's
not putting lots of
like nosebleeds for the 20 milligram. It was 40.7%. That's an insanely high number for 20 milligrams of isotretinoin.
Yeah. I think they had to have been intentionally eliciting it. Like it probably wasn't like ER, nosebleeds.
I just like when patients on acne doses of Accutane are complaining about dry lips and my nose is dry and this, I'm like, all right, we're going to go down to 10. You're not going to have any of those side effects and you're just going to have to take it for a year. And You're right. Maybe I'm not eliciting those. Well, how many is your dryness better or what? It's just
Right.
those numbers were surprising to me. What are they doing
Yeah.
over there in Turkey?
Yeah, I don't know. I don't think I've ever done like 10 milligrams a day of isotretinoin for anything. But so you know, there's probably a lot of selection.
Acne
What's that?
patients are some acne patients are like
Just can't tolerate
everything's
anything.
dry. Yeah.
So, but all right, takeaway was seems to work while you're on it.
Yeah, it sort of works while you're on it. If you're gonna do it, go big or go home. And you know,
It's like
no weight-based dosing here.
yes.
So you know, what's your Anatolian average size? I don't really know. Just wanted to throw out that adjutive.
So
and then,
I talk about Anatolians all the time.
I know.
For those of our listeners who, by context, I'm believing Anatolian means Turkish.
Yes.
So the one thing this reminded me to throw out there is don't forget that for somebody who's got sebaceous hyperplasia, isotretinoin is actually a very effective therapy. So there's some data out there, 40 milligrams a day for 2 months. Really shrinks them down, and they probably eventually do. I mean, whenever I've used it, they do eventually come back, but it can be like 5 years before they come back. The sebaceous hyperplasia, I think it's better for that than for sebderm.
I agree. That is good. I've had that with like renal transplant patients who have been on like tacrolimus and gotten lots of sebaceous hyperplasia. So yes, that's the take-home message. It had nothing to do with the paper. All right, I'm done.
Next study, Patton, what do you got?
It is from August 2025 issue of Biomedicines. I don't think I've ever read anything from Biomedicines. So excited. Actinic cheilitis, a systematic review and meta-analysis of interventions, treatment outcomes, and adverse events by Al-Farsi et al. Some general background information on actinic cheilitis, just for, general info. It is considered a precursor to SCC of the lip. I don't know why I wrote that down. Progression rates of 3.2 to 16.9 to invasive SCC. So AKs probably overtreat. I'm not worried about most AKs. We could probably leave them alone without any significant consequence. This is in, of course, the non-transplant patient. Actinic cheilitis kind of worries me when patients come in and they have like the scaling and the cracking and this doesn't heal, and you look at them and you're like, this is probably a actinic cheilitis. That I think probably deserves to be addressed more so than just run-of-the-mill cutaneous AKs. Lip SCCs have a higher metastatic potential compared to cutaneous SCCs. So they went through this 2,000 records after screening exclusions. They included 36 studies in the final.
Blah, blah, blah. Get to the point.
Efficacy was determined by clearance rates and recurrence rates. I was like meta-analyzed out at this point.
Okay.
I don't understand anything from meta-analysis. They talked about generalized linear mixed model.
What works? We don't talk about that on
what works and what doesn't work, and right. So I assume that the thing is clearance is what's the likelihood it's going to get rid of it, and then recurrence, what's the likelihood it's going to keep it from coming back, right?
Right. Two forest plots that pretty much lay it all out. CO2 laser imiquimod had the highest clearance rates. Figure 3 forest plot for recurrence rates. And once again, CO2 and imiquimod come out on top. So I guess those are the top 2 most effective options. This wasn't anything that was surprising, but I hadn't read anything on actinic cheilitis in a while. And so it was kind of nice to sort of reassure what I always thought. The problem is that most derms don't have a CO2 laser on hand. And so there'd have to be a referral. And one time I actually referred a patient with biopsy-proven actinic cheilitis to get CO2 laser because I knew this other office had it. And they sent the patient back saying, this isn't actinic cheilitis.
No.
So that was a little frustrating. And the problem with
on isotretinoin and it was just a dry lip.
It was the weirdest thing. I didn't know what to say to the patient. I'm like, I feel really bad. I mean, it's biopsy proven. We sent them the path, whatever.
You're just not that good of a doctor.
Maybe it doesn't.
All I could take
maybe it doesn't get reimbursed, and the patient didn't want to pay out of pocket. I don't know. Maybe I missed something.
All right. So the takeaway would be ideal treatment according to this then is imiquimod more so than 5-FU or other stuff that is accessible to us.
So 5-FU didn't even have a study. So it wasn't included. I think there was a study in the recurrence, but there wasn't in efficacy. And the problem with imiquimod is, like, I would never use imiquimod. If you use field therapy on the lip, it is an absolute disaster. Those patients like wind up in the ER with swollen, cracked, painful, can't eat lips. So I don't know what to do.
What if you so what I would do is, unless they give a regimen here, I would be like, okay, try putting it on just once a week for a couple weeks. If it doesn't, it's not a disaster, then try going like Monday, Thursday. And if it's not,
that's probably the way to go. It was interesting. So it was 2 studies that looked at the efficacy. So I went and looked up the studies. One of them, they did it daily for 8 weeks. The other used it 3 times a week for 4 to 6 weeks. And both papers said when it got too bad, they told the patients to stop. And conclusions from both of the authors that did those 2 separate studies were like, we need a different regimen. These reactions are absolutely terrible, but they just kind of left it open. So I think you're right, Matt. I think, like, if you're going to use topical, it is just going to be the wimpiest sort of regimen that you would ever do.
Right. Like once or twice a week forever.
Yeah. What I actually did with that patient is I did cryotherapy. That was not part of the analyses, but we have that. That's easy to do. You can actually freeze the whole bottom lip. I actually did it in like thirds. The patient tolerated it well as you tolerate any AK freezing. And it worked. She came back. The cracking was gone. It finally healed. She was very happy.
Why'd you do it in thirds so that you could charge 3 visits?
Absolutely. That's why I did it. Yeah.
No, is it so?
And I prescribed a medication as well, like TAC.
So you could get it up to level 4.
So I could get it up to a 214. Yes.
So, but you did a third of a lip at a time so that she could still eat through the other side, to whichever part.
Yeah, I thought it was a tolerance issue. I was patients first, man, with me. It's not money.
The other thing that would be interesting here, of course, we've talked about how the data seems to suggest that 5-FU calcipotriene combination is highly effective and has long-term efficacy. That'd be another option to think of to use as a, like, okay, try it a couple times a week to start, blah, blah, blah.
That is what I do.
Okay. Do you do it with like
specifically for actinic cheilitis?
Yeah. I have done. Yes, I will do it for actinic cheilitis. Everything's brutal with actinic cheilitis.
Do you have them taper up with it, or what do you do?
I just say do it. I tell them they can do it for like 5 days, and I'm like, if it just becomes too bad, just stop.
So 5 days and then you're done, or 5 days on? Then
I'll say 5 days and then you're done, and then I'll bring them back in a few months. And see
so why not do like 5 days a month? Like 5 days, like do it for 5 days, then next month do it for 5 more, the next month do it for 5 more, then come back.
I feel like you got to just sort of see these people do something, tell them do it. It's gonna be really bad. When it gets bad, stop, and then let it heal, and then come back and let me see. I feel like it's so tailored and individual with actinic cheilitis.
Okay.
Yeah. Not that I want listeners to know like how bad my skin is, but I did that combo on a little AK above my eye, like for 5 days. I was a mess for like 2 weeks. I mean, people coming in are like, "Oh my gosh, what happened to you?"
Huh?
Really?
Okay.
So, yeah. Maybe I'm just a sensitive person.
We know you're sensitive, Dr. Patton.
Thank you.
We know. All right, let's move on to my second batch here. I've got one main one that I want to get to, then a couple quickies. Some more imiquimod. So this was just a study of radiation versus imiquimod for difficult lentigo maligna. Main takeaway was that imiquimod 5% Monday through Friday for 12 weeks, tailored to putting it on enough so that they got erythema without pain, so increasing or decreasing, 92% success rate in treating lentigo maligna. So really an interesting, now 2/3 required an adjustment of frequency, or, they didn't get erythema with 5 days a week, so they had to go at a retinoid or occlusion, but tailored it to where they got some irritation, but not where they had, however frequently you had to. So up to 5 days a week. So big question here. So this is lentigo maligna, not lentigo, right? So I wasn't exactly sure if these were invasive or not. I don't think that, I think they did invasive or non-invasive. Do you guys offer this for lentigo maligna, or do you tell people to go get Mohs, or what do you, like, to me, this probably ought to be our first line treatment for lentigo maligna.
It's a discussion. I think each lentigo maligna is like its own discussion, because if it's small enough and it can get mosed off, that's generally going to be the answer. If the patient is super old,
if you have a Mohs surgeon who does it,
yes, this is why everyone should stay in academia, because then you always have that. No, but it is. I think it's just a discussion, right? And like there are 99-year-olds who, like, we should maybe do nothing with. Like, it's so individualized. I have a hard time saying this is my protocol for lentigo maligna.
Pat, what do you do?
Yeah, if it's a lentigo malignant in a patient who will tolerate surgery, then I biopsy it and I send them to surgery. And if it's a lentigo malignant in a patient where you're like, man, they would not tolerate surgery, a lot of times it's because that patient just is not in great shape, so you don't even biopsy it. You just kind of say, this probably is lentigo maligna, and it's not unreasonable to just kind of watch it and make sure it doesn't become anything more. But I suppose if I did the biopsy and it came back with the diagnosis, I like Ferris said, you have the discussion. We don't need to do anything because these are not aggressive and we can follow it. If the patient's not going to tolerate surgery, you have these two options. The problem with both of those options is radiotherapy is not great because they have to go in for like, what was the average 30 treatments, right? Yep. So I could see a family saying, we're not going to do that. And then applying imiquimod, little packets, and putting it on once a day for 12 weeks. They're not going to do, is the compliance going to be good there? It's like, there's not a lot of great options. And so you have the discussions, and if the patients are like, I want to do the easiest thing for me, it'd probably be imiquimod. And we could at least tell them that, hey, numbers are good. Do I expect them to be compliant with this particular protocol? Not really.
Okay. All right. Let's go. My other two quickies. So Premolast in the treatment of central centrifugal cicatricial alopecia, an open label pilot study. This was 20 patients, 15 patients finished it. Most of the endpoints were somewhat better at 24 weeks. It wasn't like, woo. But, right.
I said that when I read this.
What is like, woo? Serious. Something like prednisone or something, or
So it at least gives us, it suggests to me that oral roflumilast would work well, since we know oral roflumilast works better than a Premolast, or at least we strongly think that, and it's cheap, right? I try and get in some oral roflumilast plugs every episode. $6 a month on Mark Cuban's Cost Plus Pharmacy. Last time I checked, and works just as well as a Premolast. Listen to some of our prior episodes about dosing.
On that, like, what's his show? What's the show? The sharks are all on Shark Tank. Maybe you could suggest starting a oral roflumilast company, and he would invest in it because everybody would buy through it. You could market. You could have a speakers bureau. I think I see where you're going with this.
Yeah, I'm working on it.
Zyrus, you seem a little unstable, and for that reason, I'm out.
All right, and then my last one, this was actually in the Journal of Investigative Dermatology, so big time journal. This was actually a commentary about the real article, Drugs and Bugs in Atopic Dermatitis, Benefits to the Skin Microbiome from Targeted Immunotherapies. They did 4 different arms, JAK inhibitor, one arm, Dupy another arm, cyclosporin another arm, and topical steroids another arm. And basically what they showed was that Dupy and JAKs improved the skin microbiome in addition to improving the disease, whereas cyclosporin did not improve the skin microbiome. Because it's been an interesting question of, now Dupy improved it more than the JAKs, and that makes sense because IL-13, whenever it signals, it reduces antimicrobial peptide production. That's why you get covered with staph. And so Dupy, since it blocks IL-13 more densely than JAKs, it improved the microbiome more, meaning it got rid of more staph than did JAKs. But what this really showed to me, since cyclosporin didn't do that, was that getting rid of the staph isn't just because the disease got better. The drug does matter. And if So if you've got somebody who's got AD and getting a lot of infections, probably IL-13 inhibition. We don't have any evidence that one of the drugs, Dupi versus Adbry versus Ebglyss. We don't have any evidence that one of them is better at getting rid of staph than the other. But I've seen more data for Dupi and Dupi and Adbry than I have for Lebry or Ebglyss. Sorry, but I imagine all three of them equally benefit your microbiome, since we know that IL-13 inhibition helps to get rid of staph. That's the takeaway. And the other thing that was interesting here, just before I forget, I learned what quorum sensing means. I've been reading that in a lot of gut microbiome studies. So quorum sensing is that once a particular species of bacteria gets enough population density, then they can detect each other, realize, hey, we've got enough of us here that we can do something. And then they start to secrete proteases or toxins or form a biofilm or whatever. And so just an interesting thing that if you've got a little bit of staph, it may behave completely differently than if you've got a lot. Because once you get a lot, it then senses quorum and starts to make these proteases and toxins that damage your epidermis and directly as a protease and drive inflammation as a toxin. So that was interesting too.
It's like that scene in Gladiator where they're like, together we can survive, and they all get together and then they fight off the things that come at them.
That's right. All those chariots and whatever.
Yeah.
Patton, how many times a day do you think of ancient Rome, Patton?
A lot, like every day. There's a History of Rome podcast. It's got like 270 total episodes, and I listened to the whole thing, and then I started it over again and started listening again. So quite
nice.
More than anyone that I know well wants me to.
Okay. When do you listen to them?
Running, exercising.
Oh, nice.
Listening to one right now.
Okay.
Actually, an earbud.
It's way better than our podcast. I can tell you. If you're listening to ours, I advise you to switch over to that one.
And I want to let everybody know that when I listen to our episodes, I listen to them on like 2x. I can't. Oh my gosh! Do either of you listen to any podcasts at regular speed, or do you always speed them up?
I'm a 1.25x.
History of Rome, I listen to. At speed.
Yeah.
0.75, so it goes on longer.
All right. Well,
you know what I was going to say is the microbiome thing. It actually reminded me of like the hand eczema with the JAKs, right? It's like there's more to it than just calming down the inflammation, right? And steroids hurt the barrier, and that's why like it can be okay, but why JAKs may be way better. And it's just a difference of cyclosporin and Dupi. You have good responses to cyclosporin, right? You've had these atopic patients using cyclosporin, and they're like, okay, yeah, I'm better. But it's not this has totally changed my life that you get with Dupi. And I wonder if it's because it's addressing more than just the inflammation. It is addressing microbiome and you know what I mean?
And the itch sensitization, right? So the IL-13 that is IL-4 and IL-13 that are expressed on itch neurons. So you're calming down the itch neurons, you're fixing the microbiome, whereas cyclosporin is kind of doing those things, but it's only doing them by removing the inflammation. It's not actively improving antimicrobial peptide production or reducing the hypersensitivity of the itch neurons. That's interesting. All right. Well, we are going to wrap it up there. So I want to thank everybody for joining us this week. If you got questions, comments, ideas, you can shoot us an email at questions@dermsondrugs.com. I hope you learned a few things. I hope you laughed once or twice, but mostly I'm hoping you're planning to join us next week. Until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.